Hey everyone, I'm Cody Jones. I'm one of the co-owners of the Thousand Oaks office that is now Spine and Sport Thousand Oaks.
And we have
Eric Honbo. Happy to be here. Have a fun presentation and some good info here with the master Kyle and Cody and myself and a special guest Mike Socia coming up.
And for you guys that are working over there, we have our quick. Oh, there she is. Over there. All right, just to make sure that this is for real now. So I'm going to go ahead. We're going to share our screen and we're going to get going. And we have a lot to cover and we hope you enjoy the show. So let me remove this here.
Start up.
Yep. And then here we go. All right. So there we are, some three amigos. And like I said, I'm going to start out by just going over some things by treating the shoulder. So basically, when somebody comes in with a shoulder injury, you want to know, one, how did they injure their shoulder, just like normal. But you do want to know, is this an acute condition or a chronic condition? Also, is it a traumatic injury or is it atraumatic? But nevertheless, they'll most likely have some type of inflammation in that shoulder, some swelling in that shoulder. And we actually call that external impingement. And so at this point, they're going to have a difficult time to even raise the arm. But if it's a baseball player or something like that, they're pretty concerned right away that they can't lift their arm immediately after that injury. So they immediately go to, did I tear my labrum? Did I tear my rotator cuff? And at this point, if they don't have any diagnostics, you can't really tell them anything at this point. So like as we go into this external impingement, again, you can see how that space between the acromion and the bursal side of the cuff, how there's very little space. So if there's any inflammation, that's what's going to cause that pain. So for that first week, you really just want to keep them controlling that inflammation with ice. They're going to have some hypertonicity in their muscles surrounding it. So you want to decrease that and decrease their spasms. And just let them rest for 1 week, but really concentrate on icing that. And you'll see a significant improvement in their range of motion the following week. So we're going to talk a little bit about some subluxations and dislocations and how these, you also get some injuries because of this with Bankart lesions, slap tears, and rotator cuff tears. But we all know that even if they're positive on an MRI or an X-ray, that it doesn't always mean or lead to surgery. So when sometimes somebody comes in with some of that inability to raise their arm and they might be a throwing athlete, this is something that I'll do right away. This is a Sulcus Sign. It's going to take a look to see if they have multi-directional instability. So the curious thing about this is that they are getting micro subluxations over and over and over. So if they're an overhead athlete, they're going to be putting a lot of stress on that biceps tendon, and we're going to show you that in just a little bit. But nevertheless, with these type of patients, they'll get their range of motion. Don't worry about it. So primarily focus on strength and stabilization. You can see here this third baseman diving with this now. His throwing arm is a little bit unable to do anything. So he can relocate his arm himself. It's not his first time that he's dislocated, and he's going to do one more. Now it's Now I can play. This all happened even before the trainer got to him. So he's falling out on an outstretched arm again. They're going to take a look at his range of motion, his strength, and if it's all good, then can he actually throw and could he stay in the game? And if you look at the score, it's a 6-6 tie in the 7th inning, and it looks like he can make that throw. So in the following inning, we're going to see this one more time on that outstretched arm. He wants to see if he can make that throw. 7th inning, we have a 7-7 tie, and he stays into the game to get the game-winning hit. Not all shoulder dislocators are going to be able to stay in the game. So in the general population, though, an emergency room study, they found that shoulder dislocations were made up of 90% of them are anterior, and the rest are comprised of posterior and inferior. However, we know that in sports, it's just a little bit different. You can get an anterior dislocation where you get where the arm is abducted and externally rotated. You can get an inferior dislocation in which the athlete is diving into the base. And then you could also get a posterior dislocation by landing on the elbow with the forces going posteriorly right through the shoulder. And then you could also, as a lineman, which is very common, they'll get repetitive posterior forces going through that shoulder. So when you're working with these patients with the Bankart lesions, you have to know that it's not just an anterior or posterior. You have to really know where that lesion is so that you can make some good clinical decisions with your treatment. When something's like even a little bit worse, you might get a bony Bankart in the dislocation. This here is going to be probably require surgery because otherwise that arm is going to continually dislocate with their athletics. So if they do have surgery with some of these precautions, if they have a stabilization procedure, if they have an anterior stabilization, you're going to want to avoid 90-90, chest stretch, and especially the hand behind the back. We, as physical therapists, love to do the hand behind the back, see how much you can go up the spine, but you're going to put a lot of pressure on that anterior capsule. Same thing, posterior. We got to stay away from closed chain exercises and pushing type of activities. Inferior, we have to be careful of the coronal plane abduction and table slides and wall slides and even wall walks up the thing. You remember that that's how they actually dislocated their shoulders. So we have to be very careful in this position here. With the slap tears, this is something where you'll see what we talked about earlier with that person with an MDI and how he has a lot of tension on that biceps tendon, and how that biceps tendon has a direct attachment to the superior labrum. So you can see on the right, there's the tear and pulling off the labrum. You can see the Bankart lesion anterior inferior. But if you look to the far left with that surgical repair, look how close that repair is to that biceps tendon. This is something that has really sat with me for the last like 20 years in my practice. This is looking at the bicep stress with maximal external rotation. This was out in our place in Birmingham, Alabama. And I was lucky enough to do this dissection right here. So this is me dissecting it. And I've taken that external rotation, the arm into external rotation. You can see the biceps move and look at that stress that it has directly on the labrum. So you can see that if it's greater range and greater force, you're going to put repetitive stress on that superior labrum. So with the slap repairs, really, we do none to very minimal biceps activity in the first 6 weeks. You're going to remember to protect the biceps throughout the rehab and really watch the behind the back internal rotation stretch. This is a lady that we're just kind of demonstrating it on the right arm, but we never did any of these stretches. And 9 weeks later, she was fine.
Nice.
So we also have the rotator cuff tear. You can see it, this little cartoon here. But from arthroscopically, you can take a look and maybe understand a little bit more. On the left side, you can see that the rotator cuff is intact. On the right, you can see there's a hole. On the bursal side, you're seeing the cuff tear, and then you're seeing the repair. So this is one of the most important things that we as therapists have to remember, that the healing begins by the formation of this fibrovascular tissue, that interface, that IF right there. And it's actually between the tendon and the bone. And so the bone will continue to grow into that interface tissue if you allow it. And then it's going to get stronger by getting this collagen fiber continuity between the two. So why is this important? Because if we stress that, if we do muscle contractions and on maybe abduction or something, and we're doing it with tubing or something at a very early stage, maybe we're going to pull that tendon to the left, and it's going to compromise that interface. At the same time, if we do something where we go behind the back with the bone on the right side, you can see that we're going to stress that interface as well. So we have to make sure that we are protecting that interface probably up to about like 6 weeks, and then you can start getting a little bit more aggressive. So our shoulder pathway is, one, go ahead and decrease that inflammation and manage their pain and spasms. Restore range of motion, but do it in a pain-free manner. At that point, you can go ahead and start initiating cuff and scapular strength. But if you don't get the range of motion, it doesn't matter how strong they are, then they won't have a good outcome. So in red, if we have an active person or an athlete, we're going to start doing controlled strength above 90 degrees. We're going to start initiating the fast twitch muscles. Then we're going to integrate the body with the functional speed of the shoulder, and then do some pre-return and then some return to sport activities. So you have to understand the surgery. You have to know the location of the repair. You have to respect the surgeon's preference. We'll see a patient 1 week post-op, and then we'll see another patient 6 weeks post-op. So it's up to you to really understand the goals of each phase and really understand your client's goals. In phase 1, you're just going to start out with some range of motion exercises, but again, really work on that soft tissue. Phase 2, you can see on the top left, they're going to do some active assisted range of motion with the wand. And then over to the right, they're doing gravity eliminated exercises. So it's going to be very low tension on the muscle. Then we're going to go into phase 3. And now we can start doing some strengthening. We're going to continue to get the range of motion. And then we'll start doing some strengthening on the rotator cuff. Once we get above 90 degrees, I'll always have our patients come in and do just like a quick 1-minute assessment. And I'll show this at a later time as well, but this really gives us a lot of information before they come in. I do it after my hands-on treatment, and then I'll even do it after their activity, like even if they threw yesterday. So here's some of our Job exercises that we'll do, and we like to do both hands because we're going to do it slow and methodically, so we don't let momentum take it. But we use both hands so you can use the good arm to get the irradiation into the affected arm, and you'll actually get higher EMG activity using both arms. As we get into late phase 3, we're going to do some controlled exercises above 90-90. And so now we're going to start initiating our scapular routine. And it's similar to the Jobs, but we're really emphasizing the strength of the scap. So we're going to go protraction and retraction. And we're going to have these videos available for you on the Spine and Sport website as soon as Starla and I figure this out. Many of the Bankart repairs are going to be football players. They're going to feel great about 3 months, but we're going to allow them to do a full sprint at about 4 months. When we get to like dynamic strengthening, now we're going to start integrating tubing, and we're going to go using what we call 5 slow and 5 quick, so that we can get a 5 slow concentric, eccentric, and then a quick movement there. We're going to move into our non-throwing med ball routine, and we like doing it at the very slow range so they can just get used to the exercise first, and it's low tension. Probably that following week later, we're going to go ahead and we're going to increase that speed to a controlled speed, and then we'll move all the way up to ballistic movement. So here's controlled speed. You can see it's a little bit faster. We're going to add a little more weight, maybe a 4-pound med ball. And then the other one, when we first started, we'll just use like a basketball or soccer ball. So now he's going to do a more explosive. And obviously, this has to be at a greater than a 5 out of 5 muscle strength to be able to do these. You progress that on to like 2-hand plyo ball throws. We do the exact same thing. Make sure we start out nice and slow first and controlled using a soccer ball. And then we'll get a little bit more explosive.
Go. Good, best.
And then we'll have our whole routine down here. If you don't have a wall like this, you can still do a partner if you're okay with standing in front of it. What about closed chain exercises? Why and when is it appropriate? So we know that with a football player, they have to do it. But why compromise these athletes and get them to where they are getting that posterior drive through the glenoid if they're not strong enough? So if you look on the left, he's not strong enough for those scapular stabilizers. So just envision what the humeral head is doing to that posterior labrum. So go ahead, and they're not going to return back for like 7 or 8 months. So go ahead and just wait for about 6 months to let it occur. Then they can get back and they can start returning to their contact sports. When you get to returning to the activity, they're going to return to the sport in a very controlled manner, starting out with non-contact drills, sport-specific, practice, contact, and then they're going to do some light scrimmage, and then back to competition. And that's all I got. Bing. You can ask questions at the very end. Now, I turn you on over to Eric.
All right, thank you very much. I'll slide in here. Starla and Kyle, thank you so much for having Cody Cody and me join the talk, and we talked about what specialty topic maybe within overhead throwers that might be interesting. So we went a little off the board and went into a concept called ground reaction forces and how that can help play a role in your overhead throwers with mechanics and what everybody's looking at, which seems to be velocity. And before we get into this talk, we got some secret information about Kyle that even though he's got 5 clinics in Sacramento, he's really a Dodgers fan. It's unbelievable.
Let's go!
And our Padres fans down there, those are like our little brothers. So, thanks again for having us. We've been fortunate in the last 15, 20 years, similar mentors that Kyle has had, some physicians in the world of baseball medicine that are very at the forefront of the PBATs and of the national presentations, Dr. Lou Yoakum, who passed away, Dr. Luca Podesta, Dr. Elatrosh. We've really learned a ton from some of the physicians that we work with. And I'll tell you what, over the years, got to, you notice a pattern with all the docs that are really doing the surgeries on these throwers. And these are professional throwers down to kids. And they all want leg, hip, core strengthening. And so when you actually look at what generates the majority of your throw, it is 60-something percent, 70-something percent hips, core, and what's called ground force. And so if that's the case, we need to be spending a lot of our time educating these throwers and working on that here in the clinic and getting home programs, strength and conditioning. So what is ground reaction force? Well, it's a really large key into the energy transfer from the ground through your hips, trunk, into your arm and out to release point. If the athlete, and it could be a soccer player, it could be a tennis player, baseball player, exerts that force to the ground or generates a strong action, that ground is going to exert an equal and opposite force, a reaction onto the distal end or onto that athlete's ball or golf club or what have you. And so that ground force goes back up through the foot, knee, hip, trunk, and out to release point. In this case, the ball with the overhead throw. There are 2 main forces that generate ground force, right? And we're looking really at a pitcher or any thrower, but that push off leg from the back is going to initiate that kinetic energy and drive that body weight and that acceleration and that momentum onto that front leg. Front leg's going to hit the ground. It's going to put on the brake and decelerate. We'll talk a little bit about why front leg eccentric contraction and strengthening is important. And then the ground force exerts that equal and opposite force straight back up and out to release point. So we look at sometimes focusing on landing leg concepts and push off or drive leg. There's different terminology. In the case to the left with this female soccer player, what would happen if her front leg slipped out in front of her? She's going to lose this huge ground force of all that momentum going into the ground and coming back up. Same thing, if the javelin thrower here on the left, if this athlete's left foot slides out, or this knee doesn't have the eccentric control to drive force, control, stop the momentum, and then bring it straight up out of the javelin, he's going to be basically throwing with his arm. She's going to basically be kicking with her leg. And so when you hear coaches and the doctors, and all the performance specialists talk about avoiding throwing with your arm, it's basically not leveraging or teaching kids and teaching athletes to leverage that ground reaction force. Golf is exactly the same thing. I know, right? Cody has done a lot of stuff with TPI down in San Diego, Titleist Performance Institute. You got to load that ground. When they do muscle activation, EMG studies, what muscle do you think on Tiger here was firing the most right at impact? It was basically Tiger's left glute. Wasn't his pronator on his right, wasn't his internal oblique on his left, his external oblique on his right, what have you. It was that left glute driving that hip extension and into the ground to generate a equal and opposite force to that kinetic energy is going to come out through the club. So leg importance, we're talking about throwing with your arm and why we want to avoid that. Well, a 20% decrease in kinetic energy coming from your hip and trunk is going to require a 34% increase in rotational velocity at the shoulder and to impart the same amount of force at release point. So if kids and our athletes aren't getting enough hip, trunk, leg kinetic energy delivered into the ground, they're going to have to compensate somewhere. And all of us are working with athletes and with any orthopedic condition. A lot of times with repetitive use, in this case throwing, it's a timing issue, and the compensation of having to use your arm because you're not generating it through your legs and your core is what leads to a lot of these tendinosis problems, ulnar collateral ligament deficits that we're seeing. We talked about this, if 60% or the majority of throws is generated from your leg and your core, then what really should we be focusing on the strengthening, right? So there are times when in our clinic where even though we have a softball player or a baseball player and they're here, tennis player, they're here for a tendinosis or a Tommy John reconstruction, we'll spend some time, and sometimes a lot of time, working on ground reaction force, leg, core work, because A, that's what they need. B, the doctor's going to ask them that when they go back to when the patient goes back. And C, that's what we've found to give the best outcome and enable safe return to play. This is the drill. Is this the video already? Ground reaction, it basically you're looking at rotational momentum or uncoiling in the golf world. Probably the same in the baseball world. The terminology is different sport to sport. Uncoiling and force is driven through the legs and trunk, through that elbow, shoulder, elbow, hand, out to release point, in this case, the baseball. It's created by results of ground reaction force at the thrower's feet. Simply put, your back leg, we need a big push off from that rubber. Increase that linear speed. I think from handbrake, when the ball comes out of the glove, they're looking at under 2 seconds. 1.8 seconds, I can't remember the exact metric, to when that front foot's supposed to hit. So it's fast, it's hard, big stride, foot to the ground, and generate the reactive ground reaction force. On the front side, need that strength and stability. So like Kyle had asked, and we talked about earlier, eccentric loading on that front leg to help decelerate and stabilize that front leg so everything else can catapult right over it. Again, generating the maximum uncoiling energy out to ball release. We talked about, what about my shoulder? A lot of times we'll get people on a big shoulder scat program, but we'll spend a lot of time on three-dimensional multiplanar core, hip, trunk, towel drill, as well as PNF and shoulder specific stuff. Use all the bells and whistles you guys have with rollers and discs and balls and different, half kneel, tall kneel progression. So you're recruiting different core. Basically simulate sport specific as best we can. I threw this in here real quickly. This is one of the big statements I always like to read, that regardless of the mountain height, the real solution for our youth is to do less full effort pitching and more sub-maximal throwing, playing different sports, playing other positions. Mike will talk about this. Cody will talk about this. To become a successful adult pitcher, the youth should not strive to be a youth pitcher, but instead should be a young athlete. And that is what one day will make a good pitcher. That I think is probably what is needed in the youth level for baseball throwers, not necessarily focusing on velocity. We had the pleasure of working a little bit with Dr. Job. He's the physician, longtime team physician in Major League Baseball and with the Dodgers, that developed the Tommy John. Dr. Yoakum went further and it's been modified a few times. But the Tommy John surgery, for all of us in the rehab side, the Tommy John surgery doesn't automatically make the player better as much as the rehab does. If you don't have good rehab, good physical therapy, good athletic training, good exercise progressions, good knowledge, good throwing programs, to make that tissue come back with good blood supply, then you're not as well off as before surgery. So the king of kings, Dr. Job and Dr. Yoakum and all the docs you guys work with, the Giants, these are doctors that have tremendous value in what we all do as physical therapists. And that's a compliment. So we get these guys and girls back on the field. We also help the doctors and help them, make them look good. We have a quick video. Mike couldn't be here. He's traveling a little bit on his off season. Mike, as a lot of you know, long history in Major League Baseball and recently just managed our USA Olympic team in Tokyo. Yeah, another bad picture.
We could have edited that.
Yeah, the coffee
We
machine.
could have edited that. I
Oh,
think.
the video doesn't work. Sorry,
Hit
guys.
play, hit
Sorry.
play,
Yeah.
hit play, hit play, hit play, hit play,
There we go.
hit play. May need to turn your volume up. Hey everyone out there in the spinal sport world. My name is Eric Convo. This is my partner, Cody Jones. We're coming to you from Thousand Oaks, California. Formerly Advanced Physical Therapy, now partnered with Spine and Sport. And we're happy to participate in our first lunch and learn with you all. We have a special guest that's going to add some insight also into some of the topics that you're going to hear. I'd like to introduce Michael Socia. Mike, as many of you know, has had an illustrious career in Major League Baseball, both as a player, played for 10 years with the Dodgers, won a World Series championship in 1988, also as a manager in 2002 with the Los Angeles Angels of Anaheim, not the Anaheim Angels, a World Series in 2002, went on to manage Angels for another 18 years, plus or minus, and then this past summer was our manager for Team USA out in Tokyo for the Olympic Games and brought over the silver medal. We have some questions that we fielded out from the Spinal Sporters that we're going to ask Mike, and just kind of give a little prelude to some of the stuff we'll talk about today in the Lunch and Learn. So Cody, I'll let you start with it.
Mike, as competitive leagues start a lot younger now, 9, 10, 11 years old, what advice would you have for parents of children who are talented baseball players?
Yeah, I mean, I've been through this as a player and a father, and I think the biggest thing is to understand is this is your kid's time. We had our time in this game when we were young and had a chance to play it. This is important to them to play it, to understand it, to figure things out, to learn the game. The best teacher of this game is experience. So as much as we want to point our kids in the right direction, that's important to do. We have to let them go out there and experience it. You wrap your arms around the small victories, and you hug them with the tough defeats, so their self-esteem can start to move forward, and they can start to gain confidence in not only this game but in growing up. So my advice is really to support your kids, let it be their time. Understand the specific skill sets that you're going to need to continue to improve, but let these kids play and let them figure it out.
Great. Another question that came up frequently is the topic regarding velocity. And in the baseball world, we call it velo. Tons of questions, tons of concerns about how do I get velocity, what's the best approach, are there different schools of thought, long toss, weighted balls, all the different programs out there in different parts of the country. One question that was interesting is if the high school pitcher is not throwing greater than 90 miles per hour, does that mean he's not necessarily going to get any looks from scouts?
Oh no, absolutely not. I think it's tilted a little more to the left-handed pitcher. If you find a left-handed pitcher that's throwing close to the high 80s, there's no doubt he's going to draw interest from the collegiate level and the pro level. Right-handers, for some reason, they're graded a little bit more on velocity. But in the big scope of things, times have changed now where we see a lot of kids that are chasing one target in their pitching game. That's velocity, and I know that's a mistake. You can't bypass any lessons. You're not going to throw as hard as your body's going to let you throw, as your maturity is going to let you throw. You first want to understand command, getting the ball into the strike zone even at age 8, 9 years old. You want to understand changing speeds with a changeup before you go to spinning the ball with a breaking ball or slider. I think these lessons and this progression is very, very important to the development of pitchers. So when you see the pitcher that's young chasing velocity, and now we're having so many of these, a perfect game, and you see so many of these showcases where they're graded on one aspect. They light up the radar gun and they're going to draw attention. But in order to light up the radar gun, you see kids that get out of their mechanics, they're stressing the wrong parts of their body, stressing their arm. It's like a golf swing, and you swing too hard, and you might connect on one, but most of them all over the place, and you're risking injury. And these kids, that do chase velocity, and that's the one thing they chase. There's no doubt that as they get into their mid-teens and upper teens, as they're getting into high school, don't have the tools you need to keep the best pitcher you can be. Velocity will happen on its own terms. It's going to be there.
So kids don't necessarily need to chase velocity at the age of 8 or at the age of 16 or once their growth plates are closed.
They never should chase velocity.
So the guns aren't helping us.
No, I don't think they are. I think that's the main tool of the scouts. But and you know, there's no doubt that velocity is important if you have it. But let's not manufacture velocity. Let's work on getting the whole body involved. Throwing a baseball to your maximum velocity is really a coordinated effort, not just strength. You see a lot of guys really strong that don't have the coordination of not throwing the ball as hard as some kids that are very, very coordinated, have all their systems in place to where their balance is where it should be, their ground forces are transmitted the way they should be, and the ball comes out hot.
A lot of topics I think that you'll hear today: ground force reaction, core, legs, timing, total body strengthening, listening to the coaches. So it's always great to hear Mike reinforce some of these concepts.
Listen to those coaches, even if the coaches are your dad. We never want to listen to our dads.
Except for father.
Yeah, well, you gotta listen to your dads.
Yes, I'll tell your son how to do it. You can tell my daughter how to do it.
That's pretty much how it is.
Yes. Thank you so much. Again, thank you. We appreciate all the insights. Mike has, over the years, done talks with us and has been a tremendous resource in the community for youth baseball and obviously baseball all the way up to the highest level. So we hope you found some value in it.
Thank you, Mike. We really appreciate it.
Yeah.
Thanks, guys. Great to meet you guys.
Thank you.
All right, very good. We're going to stop sharing our screen. Cody has a few words, and if we have time, we'll take a few questions here. Cody.
Hi guys, thanks for joining us. Yeah, it's always hard to follow Mike Socia. We did a talk with him once, and I noticed that after he spoke, nobody listened to me afterwards, which was a little bit tough. But he really is passionate about the sport, and when he speaks, he really comes from a place of passion for the sport of baseball, and it's really fun to listen to him have that years and years later. I'll keep my portion of this short, and we can get to the question and answers. Since baseball was our topic today, I wanted to stay out of the way and let these two legends do the talking. I've been treating baseball injuries for about 17 years, but most of what I've learned from baseball injuries, I've learned osmotically from watching Eric treat, and I've picked up from his passion and from his expertise. We're very lucky at Spinal Sport to have these two, and who are probably two of the best clinicians in the country. And obviously, if they're the best in the country, they're probably the best in the world for treating baseball-related injuries.
I don't know about Kyle.
Yeah, they'll be humble now, but they really are spectacular. So what I wanted to do is I want to take a moment and back up a little bit, take a more global view for a second, and discuss developing niche markets and specialty clinics. These two are a great example of developing a specialty clinic in an area of interest and therefore creating a legacy in their own legacy, but a legacy for their companies and for their communities. What they did is they had an interest in a patient population. They worked very, very hard to become experts in that area of the field. They marketed to referring physicians, and they created this specialty or niche market clinic in their community. And because of that, they became entrenched in their community, and they became entrenched with their referring physicians. They were known as the guys to send to for baseball. And that really, really probably made their job a lot more enjoyable. It also made their companies a lot more successful. Baseball is just an example. It could be anything. It could be migraines. It could be MMA. It could be softball. It could be runners. It could be women's health. But if you have a patient population that you have an affinity for, my advice is that you seek out that patient population, get credentialed, take all of the con ed you can get. And when you feel like you're an expert in that field, we will help you work to become an expert, or you become the expert. We will help you to market that as a company, and we will go out to those doctors and get those referrals, and you will know the language, you'll speak the language, and you'll instantly come across as somebody that knows exactly what they're talking about in this field. That's how you make a specialty clinic. That's how you make a niche clinic, and that's how you become entrenched in your community for that purpose. It'll pay dividends for your career. It'll help you enjoy your patient population and your job a lot more. and it'll help your reputation within the community and beyond for that matter. So good job to these two guys for their, especially in niche clinics. They're a great example of what can be accomplished. And it's a really good idea for spine and sport to seek out these niche markets and help entrench spine and sport within your own communities.
Wow. I appreciate that. Eric, come here. Okay, sorry. Too much love there. Let's go with, we just have maybe a minute or so of questions. So let's throw it out there. We do want to say that next Lunch and Learn is going to be in Indian Wells with Kelly Davis. And again, she has a specialty niche market in there with the tennis players. So we'll be talking about the elbow down there, and we're really excited to have that